Hello everyone, this is Dr. SEHAR from Dentures-Part, your best online mentor for the preparation of INBD ADAT AFK exam. Don't forget to subscribe for my channel on YouTube and visit my website at Dentures-Part, where I'm offering several personalized and self-study smart program at a very affordable cost for all my hardworking students. Today, I have taken a topic of fixed partial denture. We start with the bridges and the bridge abutments. To start the topic of FPD, first of all, we should know what is abutment. An ideal abutment student is the one which is a natural tooth with no mobility, and that abutment tooth is there to provide support to your processes. When you are selecting any tooth as an abutment, it is important that we should know some factors. First of all, we should know that what is the crown to root ratio. Ideal is 1:2, the root being 2 times longer than the crown. That is ideal, but more realistic or clinically acceptable is 2:3, but 1:1 is the minimum ratio. So 1 is the minimum acceptable, 1:2 is the ideal, and then root configuration also decides. The roots which are tapered, conical roots, they are considered to be better abutments, the root which are flatter and rounded. Then the second thing you should know about the root, right? If the tooth is having multi-rooted root, like the molars, right? Multi-rooted root have a more surface area, so it has better support for your tooth. First molars and canine, canine are also having a longer root, they have more surface areas. Both the first molar and canine are considered to be very good, ideal as an abutment. The root which are wider faciolingally are considered to be better abutment as compared to the roots which are wider mesiodistally. Let us talk about the Ante's law. So Ante's law states that the perisegmental area, the root surface area of the abutment tooth should be greater than the teeth that are being replaced. Because if the surface area of the abutment teeth is more, that means they are going to provide more support for the teeth that are being replaced. The replaced teeth are called as a Pontic when we talk about the FPD or the bridges. Now let us see what type of patients they cannot take the bridges, the fixed bridge. Contraindications. Of course, the patient who have poor oral hygiene, high caries rate, multiple spaces in the arch, the space which is not detrimental to maintenance of arch stability or dental health, unacceptable occlusal or bruxism. Of course, these patients cannot have the bridge. And NTA fixed bridge is contraindicated when there is a ridge resorption, especially in interior. So when we talk about the anterior, there are maximum 4 anterior teeth that can be replaced by using a bridge, and for the posterior, ideal is not to replace more than 3 posterior teeth using a bridge. In these cases, we rather go for RPD. Now let us talk about different types of Pontic designs we have. So we can see the first Pontic design here, student, is the sanitary or hygienic Pontic. Why it is called a sanitary or hygienic Pontic? Because in this, the Pontic, that is your teeth, the missing teeth that you are being replaced, is called as a Pontic. It's a freestanding member of your bridge. So sanitary or hygienic Pontic is not contacting the ridge. There's a space, there's a 2 millimeter clearance between the Pontic and the ridge. That's why it's called a sanitary Pontic. It's easy to clean under this Pontic. Good access, but you'll always see that black space visible because of the clearance space there. So it does not have the good aesthetics. So in the aesthetic zones of maxillary interiors, the visible areas, you cannot use a sanitary Pontic. That is the main disadvantage. So non-aesthetic zones, or where the patient has an impaired oral hygiene, sanitary or hygienic Pontic works very good. But when aesthetic is important, minimum vertical dimension is there, you cannot give a sanitary or hygienic Pontic. Now, when we talk about the saddle or the ridge lap Pontic, this Pontic is no longer being recommended. The reason behind that, it is lapping both the sides of the ridge, buccally as well as lingually. You can see there's 2 concave areas that has been created for this Pontic, and you can have easy food accumulation, difficult to clean. The saddle ridge lap Pontic is no longer being used. Other one we have is the conical Pontic. It's a bullet Pontic. It has a pinpoint contact with the ridge. Again, molars without aesthetic requirement. Good access for oral hygiene, but aesthetic, poor aesthetic. So posterior areas where aesthetic is not of that importance, we can give a conical Pontic. So you can use all metal ceramic or all resin. Now the next one we have is modified ridge lap Pontic. Modified ridge lap Pontic is a good design. It is different from the ridge lap. If you can see, it is lapping only one side of the ridge. The buccal side, the lingual side is free. Modified ridge lap. High aesthetic. For anterior teeth, premolars, moderately easy to clean. Minimal aesthetic concerns. Modified ridge lap Pontic is a very good design. Now, ovate Pontic is considered to be most aesthetic of all. Because in the ovate pontic, actually when you give ovate pontic to the patient, firstly you have to do the surgical preparation of the ridge to create like a socket like design where the ovate pontic is placed, and it has a natural appearance as if actually the tooth is coming out of the socket. It's the most aesthetic of all, superior aesthetic. Negligible food entrapment, easy for cleaning. For the aesthetic zone like maxillary incisors, canine premolars, ovate is pretty good. But yes, let's say your patient has uncontrolled diabetes and you cannot do the surgery. Yes, ovate pontic cannot be given because surgery still has to be done, or the patient is unwilling for the surgery. You have residual ridge defect, you cannot put a ovate pontic.